So Shay, you mentioned the utilization of radial to peripheral, and I think the Impella is a great example. And I think it's important why, interventional cardiologists should know basic peripheral because cases like Impella and TAVR. I know you're the guest, but I'm gonna ask Hadi a question.
Yeah,
I
yeah.
know I know he does some complex visceral and renals. Are you a radial to mesenteric renals,
A
or are
hundred
you?
percent.
So
A
why
hundred
why would
percent.
that? Well, do you think we have the equipment to do it? The answer for me is yes, but for the audience,
Yes.
we'll
Yeah.
ask you: do we have the equipment to do mesenteric and renals via radial?
Like you said, the companies don't talk to each other, and that's not gonna happen. But because of that, we have to put things together from different companies. So I found out very early, and of course, all of us know the angle of takeoff of those vessels is so favorable from a radial standpoint. But the issue that you run into is the fact that most of the stents are 150 or 135 centimeter shaft. So you're barely exiting the guide or the sheath. And that's a problem because if you have a TUI, whatever you use, that's an extra 7 centimeters. So what I learned early on out of trial and error is to remove the TUI and place the Cook valve. It literally saves you 7 centimeters. And then most of those are osteal lesions. So when you exit the guide, you're literally right there. So you don't need any length. So you don't run in the mesenteric and renal space. You don't run into length issues as long as you solve that issue. And I've been very impressed with the Terumo Slen Guide, which is not very much used, the 7 French Slen Guide, sheathless, that allows you to really use a lot of equipment over it. What's your experience, Shay?
Yeah, I think that we've approached plenty of renals through the radial, and I think that's been an approach. I did start the renal denervation program at Lehigh Valley as well, so we've been doing that. And I always think about, while that's a femoral procedure currently, there needs to be radial procedure for the renals because that actually will be a game changer as well for these patients. But yeah, I think that it's definitely favorable. And I think just like you said, the watch out is having enough length and really being able to navigate some of the aortic tortuosity just like you would anyway. I think the major other thing is understanding what size sheath you would need based on where you're gonna troubleshoot in the target lesion, because if you take too long of a sheath, then you're gonna either go past it or be outside the hand. And then so really getting kind of really a great visual. And sometimes what I'll do is I'll take that smaller microcatheter or wire and actually judge the distance based on that. And then I'll take the sheath, the longer sheath based on that. I do that actually in the periphery too. What I'll do is I'll put the short sheath, take like the JR4 or the pigtail, and then I'll take that 150 or 200 centimeter microcatheter and kind of judge. I'll do a little test. And then I'll see where I'm at with distance, just because some of these older patients in the tortuosity, you lose length more than you would know. So I judge those distances before really going in with the sheath of choice.
And do you use any guides, 125 centimeter coronary guides for some of those interventions?
Yeah, occasionally, yeah.
And what is available in your experience, and what do you have on the shelf?
Yeah, so we have some of the sheathless guides. I haven't used a lot of them because I've been able to do a lot just from the R2P sheaths. But I think that, if that is something you're going to do a lot of, we actually don't in the coronary lab. We end up, most of our mesenterics and things like that are done by interventional radiology at our practice. So they're doing a majority of those. So I believe they do have all the flavors of the sheathless guides, but we don't carry all of them in the coronary lab.
Sam, do you use the 125?
Yeah, no, I have the 110 GR4 guide, and I think most of the time it reached nicely. In the cases that it doesn't reach, I actually use the 85 R2P, which straighten the arch, or I can go left radial, and that's why I get like a 10 centimeter. A Ikari right, someone has told me it actually works very nicely for mesenteric. I have it, but I've never used it. I don't think I have.
Short person.
Yeah, for sure.
And a short.
Exactly, which not very common where I live. Everybody is very tall. I think, I don't have any of the 120 guide. We use it, we use it for diagnostic. The other option I've used before is using a 105 radial to peripheral. I put my GR4 diagnostic or a vert and use them as selective pictures, then put a wire. The wire will straighten the catheter towards the ostium. It's just a little bit difficult in that scenario. And I think that's where I think we still missing some of the equipment. And based on that, I'm going to ask Shay and I'm going to ask Hattie, both of you guys. You have Santa wish list. You have two products that if you say today, the company is going to just within a month, they're going to make it happen. What are the two products that you're looking to have in radial to peripheral that we don't have today? Shay, I will start with you.
Okay. I think since, kind of we were discussing earlier some of the distal disease in the SFA, popliteal, and below, having the ability to image those patients from the radial. So for me, imaging is a huge part of what I do. I think an imaging catheter that gets down there would be great. The other thing is having an IVL option more than 150. We know that, it's very obvious what IVL has done for our practice in the periphery and the coronary. I think that would be another really nice option for us. So for me, it would be a longer IVL and a longer imaging catheter.
For me, obviously, adding to what you just said, thrombectomy options, 6 French compatible. You'll be surprised how much you can get done with 6 French from an arterial side. Of course, venous is a completely different animal, but just the 200 centimeter shaft, that's all we're asking for. Just make it longer. For simple-minded physicians like us, I just don't understand why they don't do it.